go. All right. Good afternoon, Lieutenant Colonel Croy. I'm Second Lieutenant Colonel Licursi, along with Second Lieutenant McLelland. Today we're going to be presenting an evidence-based review on the effects of cryotherapy on patients with musculoskeletal pain. Getting right to it, our PICO question was, in patients with musculoskeletal pain, what is the effect of cryotherapy on pain threshold, pain tolerance, and nerve conduction velocity versus any comparative treatment? So breaking down the PICO acronym, our population included patients with musculoskeletal pain. Our intervention was cryotherapy, comparing it to any comparative treatment. In a lot of the cases, no cryotherapy. And then our outcomes that were measured were nerve conduction velocity, pain threshold, and pain tolerance. Our search strategy included PubMed, Google Scholar. We also utilized the related articles feature on PubMed to get a lot of our sources. Our search terms here at the bottom. Getting into the clinical applications of cryotherapy. It's used, as we all know, in the acute phase of an inflammatory condition or right after an injury during the acute stage. It slows down the metabolism of the injury so that inflammation control, edema, and effusion control is important, especially in the acute phase. As clinicians, we don't want to be able to make certain measurements with range of motion and do various special tests, but effusion and edema, they can cause difficulty with that. So cryotherapy is going to allow us to kind of calm the area down and allow us as clinicians to make an accurate clinical diagnosis. Pain modulation, of course, everyone knows the effects of cryotherapy. With pain modulation, we're going to get more into kind of the physiology of why that occurs. And muscle spasticity. Muscles that are kind of tight and spastic and may cause certain individuals pain. Cryotherapy has had some effects, positive effects on that. Getting into the physiological effects of cryotherapy, Nadler et al. In 2004, he wrote a narrative review getting into how cryotherapy affects the acute phase of an injury, decreasing that tissue blood flow, reducing tissue metabolism, and that oxygen utilization, so kind of slowing everything down. We mentioned that those muscle spasms, muscle spasticity, decreases that, creating sort of an analgesic effect, as well as decreasing the activation threshold of nociceptors. So now we're getting into pain tolerance and pain threshold, and of course nerve conduction velocity, decreasing that, and Nadler et al. Labeled that cold-induced neuropraxia. Some of the physical agents we came across during our research and things we've heard about in class are, of course, cold and ice packs. With you have the ice packs filled, a bag full of ice, as well as the kind of the chemical gel that is put into a freezer. Ice packs with a bag of ice is generally more effective, especially if it's crushed ice. Ice massage, we learned also in class that that's very effective as well. Only 7 minutes, and the area goes numb, and it induces those physiological effects that we want. Cold water immersion is effective form of cryotherapy, especially for kind of lower extremity injuries that they can, kind of utilize gravity. Be a little difficult to dump your arm into a bucket of water, be an awkward position. Cold water immersion is very effective. Lieutenant McLelland will get into how one of the more effective forms of cryotherapy. And also, one of the things we found interesting was whole body cryotherapy, something we never really heard about. It's essentially a chamber that's brought down to extremely low temperatures, which the patient goes in, they shut the door, they wear hat gloves, masks, and kind of do certain range of motions for a limited amount of time within that chamber. And it induces the same physiological and clinical effects that we want to see cryotherapy do. However, you can see just by the looks of that machine, it's probably pretty costly. And if you were a clinician working on safety, effectiveness, and cost, you'd probably be choosing that ice bag over whole body cryotherapy. But more research to come on that. Speaking of safety, of course, with any physical agent, there are certain contraindications and precautions we need to take, especially with cold. Hypersensitivity and intolerance is big. Raynaud's disease, as well as circulatory compromise. Patients with hypertension or cardiovascular disease, cryotherapy is going to be constricting that blood flow and constricting those blood vessels. So in a patient with hypertension or cardiovascular disease, it could cause more problems if not applied correctly. More precautions you want to take into account is lack of sensation. If a patient can't feel the ice originally and they leave it on for too long, that could cause some permanent damage for sure. Any modality you want to consider an open wounds when applying a physical agent. And very young or old patients, we mentioned cold hypersensitivity and intolerance. It appears that young patients, as well as older patients, kind of on both ends of the spectrum, have a different sensitivity to cold than sort of people within the middle of that spectrum. So definitely something to take into account. Now we're going to get into the articles that we found on cryotherapy. I'll hand it off to Second Lieutenant McLelland.
Thank you, Lieutenant Licursi. As he said, I'm Lieutenant McLelland, and I'll be talking about a few articles that we found during our searches. Let's get us started with the article done in 2007 by Al Galfley and George. This article pretty much is our PICO question verbatim: the effect of cryotherapy on nerve conduction velocity, pain threshold, and pain tolerance. The design of this study, it was a within subject experimental design. They were looking at a treatment ankle using cryotherapy versus a control ankle where they were doing, they used no cryotherapy as a placebo. Measures, they were looking at the nerve conduction velocity using a portable electromyogram system, and they also looked at pain tolerance and pain threshold, PTO and PTH respectively, assessed by a pressure algometer at 2 different sites. This article was looking at adult male sports players, ages ranging from 20 to 29 years old. And in the treatment ankle, what they found the nerve conduction velocity significantly reduced, and they saw an increase in that pain threshold and pain tolerance. In conclusion, cryotherapy increases PTH and PTO associated with a significant decrease in the NCV. And reduced NCV at the ankle may be a mechanism how cryotherapy achieves its clinical goals. In this next article from 2010 by Herrera et al., motor and sensory nerve conduction are affected differently by ice pack, ice massage, and cold water immersion. So this was a randomly controlled study. They were testing the effects of cryotherapy on the sural and tibial motor nerves down in your leg. The subjects were broken into 3 groups, each group's receiving a different form of cryotherapy, whether it was ice pack, ice massage, and cold water immersion. This article stated that the skin temperatures and the speed at which the nerves conduct are directly related, so they used skin temperature measurements of the calf using infrared thermometers as their deciding factor. So what they found were that all 3 modalities were effective and in reducing the nerve conduction velocity sufficient enough to induce a hypoalgesic effect. However, that they found that cold water immersion was the most effective of the 3, and they were looking at young adults averaging age of 20.5 years old, both males and females. So from 2005, we have another article, this time by Raynor et al., looking at cryotherapy after ACL reconstruction. This was a meta-analysis. So what they were doing is they were reviewing 7 randomly controlled trials. They compared post-ACL reconstruction. So they were comparing the cryotherapy versus a placebo. To be eligible for this study, you had to perform a ACL reconstruction. 6 of the 7 either used a gracilis or semitendinosus graft and 1 was patella graft. And they were testing cryotherapy versus placebo, and to be eligible to be a placebo, they defined that as no cryotherapy or the use of cold therapy device using water at room temperature. And so what they were measuring the post-operative pain levels as well as post-operative drainage and range of motion in the knee. However, they were mostly focusing on that post-operative pain levels. The population in this study was very varying. One article had an average of 22 years old, and another one had an average of 34 years old, so it was a wide variety. They also saw a significant reduction in pain was reported compared with the placebo with a p-value of 0.02. And in this article from 1994 by Ernst and Fialka, Ice Freezes Pain, a review of the clinical effectiveness of analgesic cold therapy. So this was a systematic review, and what they were looking at the effectiveness of analgesic cold therapy on pain threshold levels. So they were focusing mostly on the pain threshold levels. So what they were doing is they found that the effect of the cryotherapy generally lasted for about 15-30 minutes before there was a significant decrease back to normal of that pain threshold. However, you did see that spike at the beginning. Population. There was a wide variety of subjects. They never really said the ages of the subjects. However, they did say that one article was looking at patients, subjects with low back pain, the effect of that cryotherapy on that pain threshold. Another one was looking at rheumatoid arthritis, and even one was looking at healthy adults, just applying cryotherapy to the shoulder and seeing if it could affect the pain threshold levels. And in conclusion, they found that localized cooling might reduce the pain, and the mechanism by which cryotherapy might elevate pain includes, and they listed these 4 different things: anti-nociceptive effect on the gate control system, a decrease in nerve conduction speed, so they were looking at both alpha delta and C fibers. And then they noted that there was a greater effect on the alpha delta fibers. However, they were citing that the C fibers were the most responsible for that pain conductance. Number 3, reduction in muscle spasms, as Lieutenant Licursi said earlier. Prevention of edema after injury is number 4. And here's Lieutenant Licursi again talking about summary and recommendations.
Okay, so kind of to wrap it all up, the big 3 of physical agents and modalities is safety, effectiveness, and cost. These 3 things we want to consider when applying modalities to our patients. So for cryotherapy, in terms of safety, you have to be sure to consider the precautions and contraindications. With any physical agent or modality, you want to monitor your patient's reactions, look at their facial expressions, keep an eye on them, get feedback, so you can kind of get a grasp on their tolerability. In general, cryotherapy is a rather tolerable modality, but again, important with any treatment really is to monitor your patients. Effectiveness. Cryotherapy, based on the articles that we found and a lot of anecdotal evidence, is certainly effective in reducing that swelling, reducing nerve conduction velocity, and producing that analgesic effect. Lieutenant McLelland just mentioned a study that said that the gate control mechanism was affected. That was an older study from 1994. A more recent study from 2007 that we found said that the gate control mechanism isn't affected, and it has more to do with the nerve conduction velocity as opposed to gate control. And of course, pain tolerance and pain threshold is going to increase when cryotherapy is applied, so it is effective in that nature. Cost, cryotherapy and ice isn't necessarily expensive. You have to consider the kind of the space the freezer is going to take up for making the ice. But the only real thing that ice and cryotherapy is going to cost you is time. 20 minutes on, 20 minutes off, 15, 20 minutes, for a patient is more than half of the available time you might have with that patient. So you want to maximize that time. However, with cryotherapy, it enables you to kind of apply it. You don't have to be there the whole time. You can see another patient, be sure to monitor, maybe hand them a bell or kind of a buzzer if they get uncomfortable, or worst case, they can remove themselves. So considering safety, effectiveness, and cost, cryotherapy is a good physical agent and modality. If you have any questions about this evidence-based review, about any of the articles, just post them on Canvas, and me and Second Lieutenant McLelland will get back to you as soon as we can and answer your questions to the best of our ability. These are our references, if you want to check them out for yourself. Other than that, have a great day.
Thank you.
Thank you.